I wish we could prescribe friends.
Maybe the real antidepressant was the friendship we made along the way.
No, but yeah, like go pick up your friend at the pharmacy and they're going to genuinely be invested in your life and hang out with you and do things. Like, is that something we could prescribe? It'd be such a protective risk factor.
How to be patient.
And welcome back to How to Be Patient, the podcast that airs every Monday with two really fun and cool residents.
Well, when this comes out, I will not be a resident. So amend yourself. You will be referring to me
with one really cool and
as
fun
doctor.
resident and also Margaret.
I will be in fellowship when this comes out.
So today we're talking about the how and the who of suicidal behavior and suicidal ideations. I know last time we kind of went into the why people die by suicide, but knowing why something happens doesn't help you predict it. And that's ultimately what we have to do a lot of times as psychiatrists, is predict why people do things. And that's why our icebreaker for today is going to be a little prediction game.
Okay.
So, Margaret, what is the weather right now in Boston?
Raining. It's raining.
It's raining right now?
It's been raining for 13 weekends in a row in Boston.
I want you to try to predict what the weather will be in 1 week in Boston.
Raining.
Exactly right now. It'll be raining right now.
Yeah.
How sure are you?
I checked the 10-day forecast, but I don't remember if I remember.
So, yeah, okay, so you checked the 10-day forecast.
Yeah.
So,
but I don't know if that's right.
If you had to put a number on it, how sure are you?
50%.
50% sure that it's probably going to rain exactly 1 week from now. Okay.
Yeah.
Now I want you to predict the weather in Boston 6 months from now.
Snow. Cold.
Okay. Exactly what it is right
degrees. There may be
Okay.
an inch of snow on the ground. Maybe.
25 degrees, maybe an inch of snow.
Mhm.
Gotcha. What about 8 months from now?
37 degrees and rainy.
Okay. How sure are you of that?
30%.
30%? You'd bet on it?
I'm not a gambling woman.
Okay. What about 20 years from now at this very moment?
I have no
What's the
idea
weather
what
gonna
that's
be in
going to look
Boston?
like. We'll see what the globe is doing.
Mm-hmm.
You want me to give you a guess?
Yeah, throw out a
Um,
guess.
20 exact years from now, like summertime.
Mm-hmm.
I'm going to guess it's going to be humid and sunny on today, 20 years from now.
Okay. And how sure are you of that?
20%, 10%.
Yeah. Would you put anything meaningful down on that guess? Like
My
if you had
reputation as
to-
a podcast.
Yeah.
No, I wouldn't.
So I think that the point of that is, even though we have all these pieces of evidence that can guide what our predictions might be, and they're reasonable guesses, right? You check the 10-day forecast, it gives you a lot of information about what it's going to be in a week. And we know Boston goes through cyclical seasons, so we can predict reasonably that it might be snowing. But we don't know that for sure. You know, if it's going to be exactly an inch of snow on the ground or a certain temperature. And the same goes for even like a few decades from now with the way climate change is going. And the point is that it's really hard to make these predictions with chaotic systems. Sorry.
Slip.
And the weather is a classic example of a chaotic system.
Yeah. Or like a
And
system
just
we
to-
don't totally understand also.
Yeah. So that's my follow-up question, which is what is chaos to you?
Doing this podcast with you. No.
True.
What is chaos to me?
In the context of like probability, what is a chaotic reaction?
I think it's like I cannot predict what's going to happen. There's no pattern. There's many different things that are impacting it that I can't either know about or don't know about. And if I know about it, I can't really calculate what they're going to do next.
Yeah.
For example,
exactly.
they might try and do a pelvic floor exercise during the middle of an episode,
Mhm.
in theory.
But the interesting thing about a chaotic system, which first of all, you said it perfectly, I think, is that you have some system that is nearly unpredictable, but each of its like small factors is made up of non-random interactions. But when combined into a system, becomes so complex that you can't tell which way it's going to go. So a great example of this could be like a coin flip. You could argue is like a chaotic reaction where it appears random to us. There's a 50% chance of it landing on heads or tails. But if you could perfectly recreate every scenario where like the amount of pressure I apply on my thumb, where the quarter's sitting on my thumb, and I flip it in the exact same temperature, pressure, weather conditions, it will land in the same position every time. Because none of those interactions are random in themselves, but because it's a chaotic system,
Right.
it produces seemingly random outcomes.
Right.
So what's interesting about weathers is something that we call like a type 1 chaotic system.
Wait, where did these
And
types come from? You're going to
So
tell me.
I'm stealing this from the book Sapiens.
Okay.
I don't know if you've ever read that.
I haven't
I
read
haven't
it.
seen much about it elsewhere, but I thought it was a really interesting model that the author used. So type 1 chaotic system is something that's really challenging to predict, and it's everything like we'd say with like a hurricane or weather. But then there's a type 2 chaotic system. And the difference is a type 2 chaotic system, one of the factors that makes this challenging to predict is that when you probe it or kind of inquire about its prediction, it also changes the outcome.
Oh, so it's like
So-
Schrodinger's chaotic system a
Yes,
little bit.
yeah.
Or
So
the
like
observer
the
effect.
economy is like a perfect example of a type 2 chaotic system where inflation, if you're trying to predict inflation, by asking people about their concerns for inflation and raising fears about inflation, you're actually going to affect the outcome of what you're seeking. Well, and what is the economy but a bunch of different combined human behaviors and decisions?
Which are also,
Type 2 chaotic
yeah.
systems.
so it's
Yeah.
chaos going into chaos.
Right. And then that comes to our job as psychiatrists, which is how do you look at a population of humans with infinite interactions, chaotic factors, and then immeasurable, non-random interactions, and try to predict people's behavior and try to guess from the population who is going to attempt suicide and who's going to complete suicide.
Because you mentioned the one where it's like it changes it by observing it. Do you think of that in psychiatry as like, I could see an argument that it like when we ask about it, it can impact it, whether that's towards the outcome we want or towards the outcome we don't want as like a type 2 system.
Exactly.
Yeah.
And so by investigating, we are absolutely probing it. I think there was a time in the past where we thought that merely bringing up suicide or asking about it was pushing it towards the outcome we were avoiding. And I think we know that not to be as true now.
Yeah, although there are people saying that in the public media, and I'm currently reading the book Bad Therapy, Against My Will, and the first chapter is her talking about children being screened for depression and their suicide question. So just to say, you're right, the field doesn't think that suggestion alone causes it, but there definitely are modern naysayers.
Yeah, it's just like the skepticism is like, what if you ask someone if they're suicidal? They're like, I never thought of that.
Yeah, basically, literally, it's like,
wait, you mean killing myself is an option?
Literally the
Hot
opening
dog,
vignette.
thanks, psychiatrist.
the opening vignette of the book is like a scary male nurse came in and told my son that suicide existed. Like, that is the
Yeah.
opening chat. It's like, what? Anyway, we won't. Let us know if you want us to talk about that book.
Yeah, exactly. So if you're so the point is that we change the system by trying to ask it questions, and then now we have this like almost impossible task of trying to predict the behavior of the population. And I think that's like one thing that is both like fascinating and frustrating to me about psychiatry, because we have such limitations on the tools that we can use, and we have like some of the hardest problems in medicine
Yeah.
to solve.
Certainly, like, my sister's an oncologist, so I'm thinking about her. But like, there's something so, because we don't understand, because psychiatry is so wrapped up in people's like personhood, there's also this sense of like when a parent asks you, what do I do with my child that like had an attempt or like was like suicidal, and then they want an answer, and we're like, well, we have these, and that's kind of reasonably reassuring, but we can't be like, here's an image, here's a lab that says they won't have another attempt or that they're safe now. And that, to your point, is like so much chaos into chaos in terms of this really important and kind of often tragic question for people.
And it's true for anything. Like, even if you show someone that the tumor is removed, they still have to tolerate the risk of it coming back.
Yeah.
But we don't give them that tangible reassurance. Like, you really have to sit in the uncomfort of the risk and be like very intimate with how powerless you are.
Yeah. Yeah.
And so that sucks, but it's also like, I think, a growing experience. But when we return from this short break, we will go over the numbers of who and how people complete suicide and how we can account for those in society.
Hey, Preston, what does this sound remind you of?
Oh, God, it makes me think about being on call. It's the pager.
Okay, well, it's not my pager, but it is equally stressful and is the timer I use for studying.
Oh, we got a Pomodoro queen over here.
Do you know what has made studying less stressful, though?
What?
Now You Know Psych. You familiar?
Am I familiar? I use Now You Know Psych for my in-training exams. Are we talking about the same thing? That excellent resource that has thousands of questions with associated flashcards, organized content in a user-friendly way?
You use it for Prite. I'm using it for the board exams. But yes, we are talking about the same resource.
We can use it for both? Ayo.
Ready to take your exam prep to the next level? Go to nowyouknowpsych.com and enter the code BEPATIENT at checkout for 20% off. That's nowyouknowpsych.com.
Hey, so I want to talk to you about this new podcast I think every clinician should be aware of. It's the Sepsis Spectrum from Sepsis Alliance, and it's done by this great critical care nurse, Nicole Kupchik.
You may be asking, why are two psychiatrists talking about sepsis? But if you've spent any time in the hospital where psychiatrists or mental health practitioners go, you know that whenever someone's mental status is altered, we can be called. And not knowing the signs of sepsis, whether that's in the ICU, the ED, or other places in the hospital, can mean that we're missing things alongside the team for things that'll really impact our patients.
Yeah, I mean, delirium comes on quick and fast, and you have to keep it on your differential. It's hit me on the inpatient psych floor. And even for nurses that work in mental health and don't think they're going to come across this stuff, it's going to come across you. So it's important just to keep it on your radar, and I think this is a great resource for it. So if you want, you can listen to the Sepsis Spectrum wherever you get your podcasts, or you can watch it on Sepsis Alliance's YouTube channel.
To learn how you can earn free nursing CE credits just by listening, visit sepsispodcast.org. That's SEPSIS podcast.org for more information.
So when we try to figure out who in the population is going to die by suicide, let's look at some of the risks here. So, and I know you're familiar with all of these, but I'm going to play some trivia with you as what the actual stats are.
Okay.
So what is the lifetime risk of death by suicide for a man and a woman, respectively?
In the US or globally?
Let's do in the US.
I would guess 2% for men, 1% for women.
That is very close. It's 1.5% for men and 0.5% for women.
Interesting. I did read that chapter today. I'm sorry. I'm ruining your trivia.
No, the point of the trivia isn't for you to get it right or wrong. It's just for people to kind of like think along with you.
This is actually a test.
You know?
So
yeah.
it's more fun when I get it wrong.
The podcast is only successful if I can like catch Margaret in a lapse of judgment or knowledge.
That's why we couldn't get any sponsors.
Point of all of this. Yeah. Yeah. So
okay.
So that's kind of crazy to think about, right? Like 1 in 100 people.
That's a 3 times difference?
Yeah, 3 times difference. And so now when we move on, let's say, okay, so we have 1.5% of all men. So basically 1 to 2 men in a group of 100 will die by suicide in their lifetime. And maybe one of them will be a woman. What about the risk for a suicide attempt?
That is
lifetime
higher in women. So maybe 3% of women and 2% of men.
It's actually higher than that. So it's
really?
3 to 5% of men, and it's 8 to 10% for women.
Damn. So like almost 1 in 10 women
will have a suicide attempt at some point in their lifetime.
What do you make of the difference between the attempts and then the death by suicide?
So that's something that we can kind of get more into when we talk about means, but that's like what's a lot of is attributed to that.
Mm-hmm.
So men are much more likely to choose violent and higher lethality means. And what I'm getting is firearms, where women are far more likely to choose something like overdose, which is one of the least lethal means. So now when you're trying to kind of figure out, okay, baseline, right? Men 1.5%, women 0.5%. Now we have an entire list of factors. So we have gender, which we already talked about. Then we have race, age, socioeconomic status, psychiatric status. What of all these things in someone's history and their actions, in their life, what is the strongest risk
Of the ones you just listed,
of any of the thing that could fall under that?
from like age, I would think, older age.
So, yeah, the strongest risk factor out of all of them, and this is like this thing that you would see on your board exams or MBMEs, is the previous suicide attempt,
Mhm.
which is kind of like I've always balked at that one a little bit. And not that it's not relevant, because if I'm doing a clinical exam on a patient and I see that they have a previous suicide attempt, that
For
kind of
sure.
like sets off all of my red flags, makes me concerned. I've just found that like when we talk about risk factors for anything, and then like the strongest risk factor is that it's happened before. You know what I mean?
You want it
Like,
to be more interesting than
well,
that.
but it's like that for everything,
It
right?
is,
Like
yeah.
the strongest risk factor for heart attack is like a previous heart attack, or
Yeah.
the same thing for stroke, or like other things. So it's like, yes, I get it,
So
but like,
your
is
beef with it is that
it's kind of like a self-insistent risk factor. It's like
it
redundant.
insists
You know what I
on
mean?
itself. Yeah.
Yes, dude, because it's like it already happened. Like, obviously,
But like if someone gets pregnant, it's not a risk factor that they'll get pregnant again.
Are you sure about that? Like, are pregnant women more likely to get pregnant again than other women who don't get pregnant at all?
Maybe, but not in the same linear way.
Yeah, I guess the point is, like, I just find it to be like an unsatisfying.
I think you think it's an
risk factor to have.
unfun fact. You're like, this isn't
Yeah,
where's the creativity here?
but okay, so that's when we know, right? The strongest risk factor for suicide completion. What is the actual multiplier, though? So if you were to say, okay, we have this baseline risk, how much does it multiply their lifetime risk by to have a previous suicide attempt?
And the original is like somewhere between 0.5 to 1%. I would say like
Mm-hmm.
10 times.
38 times.
Damn. To die by suicide or to have another attempt.
Mm-hmm. In
guess-
lifetime.
Wow.
Yeah.
Yeah. I
And
mean,
the next strongest one is untreated major depressive disorder. What do you think that multiplier is?
now I'm like, I don't know what to guess. 15 times?
It's about 30 times.
Wow.
Somewhere between 20 and 30. And that one is actually higher in men, or higher in women than it is in men. So this one is like really important to us, because the history of a suicide attempt isn't something you can change. You can try to modify the risk going forward, but it's a non-modifiable historic risk factor.
Right.
But untreated major depressive disorder is something you can actually modify. So these are like some things we really emphasize and target.
Right.
So if you think about it, like if somebody has, a 30x risk of death by suicide in a lifetime, and it's a man with untreated depression because of that, that's like a 30 to like a 25 to 35% lifetime risk of
Right.
suicide in someone who just kind of white knuckles their depression their whole
Right.
life. That is really high.
Yeah.
Now all of a sudden,
Yeah.
you go from 1 in 100 to, okay, let's look at just people with depression, don't treat it. Now it's 1 in 3.
Yeah. Yeah. And then if they had both a prior attempt and that, does it go? Is it additive?
So this is where like my math runs into its limitations, because if you
Fair.
just try
That's
to
fair.
start, if you try to keep like multiplying these factors out, because they're all based off of like being pulled from the general population, it's hard to kind of compound them.
Yeah.
I actually used ChatGPT to like do some estimates with this. And it was like, well, like, technically it'd be like 150% chance of dying by suicide if you include all these factors, which is like incorrect. But if you
Yeah.
truncate for reality, it becomes more like 50%.
Right. Because it's like how many people with depression, like the increased risk is
They
not
confound,
totally
they lose potency,
separate.
I
Yeah.
guess.
Yeah. Statistics. Can we put the Timothy Chalamet picture in there?
Okay, so now going down the line, we have next highest, which is substance use disorders.
Yeah.
Active substance use disorders.
Yeah.
What would you say that multiplier is?
20 times.
Yeah, it's about 10 to 15. So
Okay.
just
Damn.
under
I thought I got
20.
it exactly right.
Yeah. So now I'm just going to kind of go rapid fire down the rest of them. So we have access to firearms. This is another big one that we target a lot. This increases the risk by about 5 to 8% in men and 3 to 4% in women. Then we have social isolation, about a 4 times multiplier, unemployment 3 times, chronic pain, childhood trauma, family history, all about 2 times multiplying your risk. And then we have active bipolar disorder, 15 times.
Yeah.
So it's like on par with depression and substance use.
With bipolar, the risk is more increased in depressive or mixed states. the mania.
It's the highest in mixed states.
Yeah, but that was just an aside. Like versus mania.
Fun fact for Pride.
Yeah.
Yeah. Yeah, but like manic people are less likely to die by suicide.
Yeah.
And then also people with major or bipolar disorder spend much more time in depression than they do in mania.
Yeah.
So like time under tension, I guess, for that, gives them more exposure to that risk. Then schizophrenia is one that's really interesting. So it has an 8 to 10% risk that's like often listed in textbooks. I was actually listening to the podcast, the Psychiatry Bootcamp podcast with Dr. Tyler Black.
Yeah.
Yeah. Super good podcast. But one of the things he brought up in there.
You're not going to shade. Okay. What's the but?
Oh, sorry. And
okay.
Super cool podcast. And one of the things that he brought up, there's no buts here.
This is our first podcast beef, our first enemy of the pod. I think one of their producers messaged me actually and was like, "Hey, we love your pod." So
no, I really appreciate Tyler Black, and he talks a lot about like the Durkheim criteria too. Anyways, he was bringing up how the risk of suicide and schizophrenia decays throughout your lifetime. The longer you spend in like with the psychotic illness, the less lifetime risk you have. So it's like that 8 to 10% is very proximal to the diagnosis, but then over the lifetime with schizophrenia, it comes out to be about 5% the longer you survive.
Yeah.
So he was saying that actually math textbooks will like use this statistic we have, like the 10% risk of death by suicide, and like use it to mock physicians as to how bad we are at math.
Wait, what? How? Well, I guess I'll have to go listen to that podcast to find out.
It's because we don't take into account that like the risk is dynamic and it's changing as people like age out. And we just took this study where we looked at like this amount of people with schizophrenia die by suicide and said 10%, then didn't take into account that like a higher rate die earlier on in the diagnosis and a lower rate die later on.
I mean, it's kind of like the like substance use one, that it's like is the reason that there's a higher rate among like opioid and alcohol users. Like based on what the substance does, based on clinically what I've seen, and like knowing kind of the overview of the land, like that statistic could make you think like, oh, there's like the same effect. But the reality is that those would have much different effects that could end up in the same kind of 10%, whatever.
Yeah. Two very different roads that lead you to the same outcome. Yeah, exactly. And then kind of now moving into the other like lower impact factors, but still important. So we have PTSD, personality disorders, and LGBTQ or like gender dysphoria, all around like somewhere between like the 2 to 5% factor range. We have traumatic brain injury, and then we have older age, all around like 1 to 3.
Yeah.
So when you look at someone and you say, okay, they're a white male in their mid 60s with a family history of suicide, traumatic brain injury, and traumatic childhood. Those are all going to like greatly increase the risk for suicide as you kind of multiply it up, but you can't change any of those.
Right.
And that kind of gets into the part of like, okay, how do we actually like, this person's at a high risk, I think, maybe they have a lifetime risk of 10%, but how do I predict what's going to happen right now? I know,
how you communicate
so
it.
Kind of, yeah, exactly. So to reference the weather prediction earlier, I know that it's probably going to snow in Boston sometime this winter, but I don't know if it's going to snow tomorrow, and like it's really hard to predict that.
Right.
So we know there's a high risk of them in their lifetime dying by suicide, but it's hard to tell right now, do they need to go in the hospital or not, which is often the choice that we have to make.
Which does feel like similar to kind of the feeling people describe with like terminal cancers, that are like cancers that they're like, okay, you're in remission now. But I mean, I think that like, right, if we're seeing someone in the emergency department, or if we're talking about this in depth, like this is kind of active for them. It's kind of like, we don't know when the next like flare will attack again. Or like with like a heart attack. It's like, yeah, you're now at higher risk for this to happen again. Here are some things we can generally do to help it prevent that happening, but you're also just at heightened risk regardless, and we can't tell you when it's going to happen again.
Yeah. And I think that's actually similar, like where us in cardiology have like very similar approaches, where the cardiologist then says, okay, but I know if you're on a blood thinner or like an antiplatelet medication, that's going to reduce your overall risk.
Yeah. Or
on a statin or something like that. So we can modify those risk factors, but we can't modify the fact that you have a family history of a heart attack or those other things. And So now to kind of like look at the impact of these interventions we have, you take someone who, like a male, who has depression and access to a firearm, just those two factors alone increases their lifetime risk to about 40%. We have an 8 times multiplier for owning a firearm and like up to like 25 to 30 times for untreated depression. So if you as a psychiatrist treat their depression and remove their access to their firearm, you can reasonably reduce their
big risk reduction.
lifetime suicide risk by like 30%.
Right.
Which is a really substantial number. It makes a big difference.
And I think it like gets at something that is not something I necessarily think about every time I do a risk assessment. Beyond like if someone's had like attempts in the past, but this idea of all of these things, we should talk about all of them and make a safety plan for like reducing all the modifiable things, but like actually knowing the numbers that you're saying of, okay, but this harping on the firearm may be, at least with the knowledge we have now, may be like way more effective compared to harping on the thing that might change their likelihood 2 to 3 times down.
Yeah. And like we can't make these like perfectly neat extrapolations from these population data sets, but it actually was so helpful for me to kind of look at the impact factors or effect sizes of them. Because, so for example, when I'm doing, I don't know, do you work in the VA?
I did in med school, not here.
Okay, yeah. So we have to do all these like comprehensive suicide risk screeners and like make these assessments.
Yeah.
And it's just like unlimited check boxes for all of these risk factors. And you just kind of check them off willy-nilly. And you're like, okay, TBI, older age, male, access to firearms. And it's like, we have like small effect, huge effect, like, yeah, he's unemployed and he has chronic pain and he's not housed. Like all of those have like a 1 to 2% effect on it. But also he has untreated depression and
a gun
and access to a firearm, and it's like, okay, if you only focused on 2 of those factors, like you're effectively reducing the risk way more than any of the others combined.
Right. It's like the use of like, I think for like primary care doctors, right, that there's not how you triage the time you actually have in clinical care with someone. It's not like we have always endless time to spend with people, even in these settings where we maybe wish we would. So like, how are you going to use that time? Are you going to use it on the one that's going to reduce it 3 times or like go down from 3 to 1% or go down from 30 to 1%?
And also like the amount of effort you put into solving someone's chronic pain is probably not going to get you a lot of output.
I'm in chronic pain, so I'm like, no. But yes, you're right.
Yeah, sorry. Well, I'm referring to like, emergency department at 2 a.m.
Pain problem
like, I've got it, guys. We're going to reduce the chronic pain, and also I'm going to like
CBT speed run.
I'm going to build you a house and buy you I'm going to build you a house and get you a job.
It's going to be a whole thing.
Yeah. So, but kind of taking that part of how we modify these risk factors, when you kind of think about employing population safety, taking into account how people die by suicide is really important.
Yes.
So just like how we talked about, removing the firearm from the home makes a big difference for people. And we see that like death by firearms, I don't have the numbers for this, but it's much higher in the United States.
I actually do have the
in other
numbers
countries
for this.
that don't have access.
I have the numbers for this, I think.
Oh, okay.
Well, wait, I don't have the direct numbers, but one thing that was interesting in statistics, they were talking about this in this chapter in the Kaplan and Sadek's Comprehensive Textbook of Psychiatry. It's a new version. But they looked at the data for suicide in between 2000 and 2019, and the global age standardized rate of suicide has fallen 36%. But in the US in that time period, it went up 17%.
Oopsie.
And one of the things that they were talking about beyond like the most common methods, which like in Europe is again, not basically everywhere besides like the Americas. Like in Europe, it was like hanging. Others, it was like self-poisoning, suffocation in Africa and Latin America and Asia. But one of the things was like, they mentioned specifically a time, like just they mentioned what you're saying of like where there is less access to guns. The method changes, but also it looks like a correlation in terms of the amount and like why it's gone down everywhere besides the US.
Yeah. And that brings up a really interesting fallacy that people think about with suicide, which is if you remove the means, people will inevitably find another method.
Right.
That what we find is not true.
Yeah.
When you remove access to the means, it reduces the overall rate of suicide, period.
Mhm.
So when I was kind of actually studying a lot of these methods, I was finding that when countries would employ new policies or barriers to accessing that method, they would see drastic reductions in their suicide completion.
Yeah.
One really interesting case study of that was in Sri Lanka in like the 1990s and early 2000s. Are you
Mhm.
familiar with this?
No.
So they had a lot of access to pesticides out these like rural
Yeah.
farmers.
Yeah.
Like sarin gas, acetylcholinesterase inhibitor type situations. And so they would take these organophosphates and they would overdose on them. So I know we mentioned that overdose is the most common form of suicide here in the US. People die at a rate of about 2 to 4% with overdoses in developed countries. And it's usually with Tylenol.
Mhm.
But if you overdose on organophosphate or one of those pesticides in Sri Lanka, the death rate is like 60%.
Right. So there's a much higher
It's
lethality.
extremely effective. So actually Sri Lanka in like the late 90s and early 2000s had like one of the highest rates of suicide in the world.
Wow.
So they banned all access to the pesticides.
Yeah.
And it saw a huge drop in the amount of completed suicides.
Yeah. Well, related to this, I think the one I had read about that was like another public like structural thing that gets at this point was I think it was in like the mid 80s, early 90s when there was a more strict prohibition on alcohol within USSR, and that they saw a huge drop similarly in like death by suicide attempts that were documented. And while the alcohol wasn't the thing that was the poison or the means, it gets at this point of kind of like impulsivity that is part of. We talked about this last time, or you had mentioned it, of the kind of like the final burst to actually have an attempt. And if you think about the combination of like structural things like access to alcohol or access to highly lethal means, and if you remove those different elements that people need, then you make it much more difficult you make it less likely that the impulsive moment is going to happen with access and like that the impulsivity will be there at all, which I think is interesting.
Yeah, you remove both the gasoline and the flame
Mhm.
at the same time.
Yeah.
And it's like it's always been so fascinating to me how we like do these really thorough population studies to come to the conclusion that like if people have less access to dangerous things, they're less likely to hurt themselves.
Yeah.
It's always like so funny how it comes like full circle with
Like,
these like
water is
intuitive
wet.
things. Yeah. But another like great example of that is with nets on bridges actually.
Yeah.
So falling used to be a really high, like very common way that people die by suicide. And then a lot of like the Golden Gate Bridge is like one of the leaders. There was a very famous one for suicide. I think they've had like hundreds, if not thousands of attempts. And I think only 20 people have survived from the Golden Gate Bridge.
Wow.
It's a very lethal place.
Yeah.
Same with like the Coronado Bridge and other places. So they just introduce all these nets and then they see this giant drop in suicide rates. The same thing in like a lot of Asian countries. People would die by jumping in front of trains. And they
Yeah, I
introduced
saw
different kind of
that one
barriers or
too.
things that prevented that and made a big difference for them as well. And those are all like kind of examples that refute someone would just find another place to jump. Like we put a net in we spend millions of dollars putting in nets under the Golden Gate Bridge. Why don't they go jump off this office building? But they don't.
Yeah. Well, and I think the underlying incorrect assumption is that people who have suicide attempts or die by suicide, that it's because it's this like stereotyped image of like they have been depressed for a long, long time and have this persevering like desire to die and will find it at any means. And it's like there are people like that, like in the population for sure. But there are also many people who something's like we talked about in the last episode, something happens, there's a sudden loss, there's an alteration in your physiology.
Their
with
coping
substance.
skills are overwhelmed.
Yeah. Yeah. And if there's an option right there, then it's like a lot easier just to act on it, especially if it's something that
A commuter bridge.
Yeah.
Something that you're traversing
or something
literally
instant
anyways.
too.
Yeah. So this was really fascinating to me. We had one of the survivors actually that jumped off the Golden Gate Bridge came and talked at my
Oh wow.
university. And I wasn't familiar with psychiatry at the time, but he was talking about how he became pretty depressed and he started hearing voices and the voices were telling him to do things. And we were all kind of like, wow, this is so weird. And looking back at it now, he had major depression with psychotic features. that was kind of leading him to act like this. But even with like how severe his illness was, he said like without a doubt, the second that he like his feet left the platform and he jumped, he regretted it.
Yeah.
Like this, like as he's like going towards the water, every ounce of his being was like, I wish I wouldn't have done this.
Yeah.
And what was really fascinating, I didn't verify this, but he shared it with me. He said, because I think he met with the other survivors from the Golden Gate Bridge, and it's like a pretty small coterie of people that have done this. It's like under 20, I think, are living right now. And it's 100% across the board.
Wow.
Every single one of them regretted it when they jumped.
Yeah. Yeah. Which gets to the point of the...
It's impulsive and it's uncertain and it's scary. It's not, I've made up my mind and I'm just going to keep trying until I die.
I know we talked about, like, not to harp on one example, but like the White Lotus episode in the recent season. But I do think their depiction was, dark and is hard to watch, but also like the uncertainty that the dad kept having these recurrent dreams of like ways that he would, spoilers, whatever, you should know this right now. We've already spoiled it. Like he would die or his family members would, and I did think that like iterative imagining and having like dreams and uncertainty is more realistic for at least a good portion of patients I've seen who struggle with like suicidality or have had a suicide attempt in the past.
Yeah, it's an act that occurs under extreme tension.
Yeah.
From a lot of different directions. So I know we didn't talk about the numbers for the means of how people die, but just to kind of put them in reference, the number one or the most lethal method that people try is via firearms, and that has an 85 to 90% completion rate, which is honestly unbelievable, and it's nearly 50% higher than like the next closest, which is like either jumping from height or carbon monoxide poisoning. But even carbon monoxide poisoning is going down because we've introduced catalytic converters and we've put filters on gas stoves. So people are less likely to die from that. So when you look at the most common attempt being like overdose, which is like 2 to 4% rate of lethality versus 90% with firearms,
right,
it can kind of help you understand why, even though men attempt much less, they have a much higher rate of completion. If you look at the overall suicide victims via firearm, 87% of them are men.
Right. And I know we make, right now it's June, it is Men's Mental Health Month. I know I make jokes, but I do think there's also something about the like, why do men use more lethal means? And there's a lot of things we could talk about with that, but I also just, the ability for men to talk about their emotions and their struggles and have it be heard. And that, to me, it feels like there is a connection between choosing a highly lethal method and the like terror that a lot of boys and men have been raised with of being able to talk about feeling ill or feeling weak or feeling really depressed and down, especially if that's not something that they've seen someone get help for or had like friends or family members show it's possible to get help for and not be shamed for.
Yeah. I can only kind of guess why. I think that there's a lot of anger and hatred, self-hatred that kind of goes into like depression with men.
Yeah.
Often like it's hard for men to express these like feelings of like hopelessness or sadness, and it all just kind of gets repackaged as anger. And when you're angry, you want to destroy things. And I think part of it is like this kind of desire to destroy yourself, which leads people to use like a lot more violent means.
Yeah.
And yeah, I'm not sure why. One thing that was interesting to me as I was kind of reading about some of the statistics were the states, the U.S. states that have the highest rate of suicide per capita. And they were all these states with low population density and like high rates of isolation, alcohol use, and access to firearms. So it was like it's like Montana, Utah, Alaska, Wyoming are all pretty high up. And I guess it makes me just think of like someone who's like isolated and alone.
Yeah. I mean, that's one of the elements. There's also the elements of like, what is the government structure and support? One of like, there are more populated for the ones, I know New York and Massachusetts were in the top, like the 5 with the least, and they are more populated. There's also, at least speaking for my state, in Massachusetts, there's more government involvement in terms of like having a broad mental health safety net system. Just to add that I think you're right in terms of the loneliness, but I also think that there's possibly also a component of what are the structural things that impact those
Yes,
numbers.
and.
Yeah.
And like any chaotic system that we're studying, it's so hard for us to tell what's causing what. We just know that when this factor is present, this outcome is not.
Yeah.
And vice versa. So in summary, we have a lot of different ways that people may attempt to take their own life, and it's hard to necessarily figure out who. We have these risk factors that are modifiable and non-modifiable. What we do know is that when you institute laws that restrict access to these means, it changes outcomes. And either putting in nets under bridges, barriers in front of trains, or gun safety laws, they end up being suicide safety laws.
Right. Yeah.
As far as the completion of suicide is concerned. We're going to take a quick break. And then when we come back, we're going to kind of talk about how do you address this with the patient in the room and go through the fabled safety plan. I think we spend a lot of time talking and agonizing over.
Yes. We'll be right back. We are now going to take some of the things we've talked about that are theories and numbers and research on this, but take it into the clinic. We're going to
distill entire life stories into bullets and paperwork.
We know psychiatrists and we know you love numbers, so that's what we're about. I kind of miss math sometimes in psychiatry. So I did not make a mnemonic for this, but I did give us 3 steps to thinking about it that I think can apply in outpatient, where sometimes I think this is a little bit actually harder because the fact that someone has been either brought into the ED or brought themselves in says something, I think, not that you will say they definitely need hospitalization, and there's still like a lot that goes into that, but that elevates the level of kind of seriousness and concern that we should have if someone is or been brought into the ED, someone in their life or they themselves were so worried they could not stay safe at home that they came to the ED in a lot of those cases. In outpatient, it's not as clear. It doesn't have that indication. And we also, when we think about treatment, especially for folks who have maybe had depression for a long time or they've had chronic suicidality, but like they have never had an attempt, all these risk factors we just talked about,
they just kind of float in the ether.
Yeah. And it's like we don't have this Pollyanna view of inpatient psychiatric hospitalization, that it's necessarily the balm for every single person that would go there, or that, more importantly, maybe that pulling them away from the other parts of their life and all the different kind of socioeconomic factors that could include will make life better and make the depression better. So my first point is find the story, which why did I make these so cheesy? I did. So I think the first thing when we think about like patient interactions, or when I see any of my patients, presumably we're talking about cases where something has changed or emerged about their suicidal thoughts, planning, actions, self-harm, substance use, some of these risk factors we've talked about, right? And so I always think if someone brings that in, often my patients will like bring that in and kind of say it in the outpatient setting of like, I've been struggling more with this. First, finding their narrative they have, as well as things that have changed in terms of this chaotic system, that there's not always a clear-cut pattern, but often when people are in this really acutely depressed state or in crisis, it's hard for them to see any patterns that can actually help bring some comfort in terms of like, am I always going to feel this depressed or this dysregulated? So first, just getting their narrative, and then also kind of being the executive function sometimes in the room when they're in a crisis state can be really important and is clinically important in terms of you'll start hearing some of these risk factor parts.
So it's like identifying where the emotional turbulence has kind of thrown them from their baseline.
Yeah.
And trying to establish like what's leading them to this moment right
Yes,
now.
exactly. And like I want to say there are some people where it will, for whatever reason, like the crisis or the change in depression or the bipolar mixed state has emerged without any changes across all these different domains I'm about to kind of list. That those people do exist, and that's always an option. But I also think that there are often changes that impact these other risk factors. And so we don't want to just say like, be bioessentialist in some ways and like, oh, we know nothing about these other parts that impact it in this chaotic system. Um, so beyond like the depression getting worse or like bipolar illness getting worse, I think some of the main things that I will elicit from people for their narrative around this. So if you're an outpatient, right? You've started outpatient this year. What
Mhm.
are some of the things you ask about if I came in? Actually, we're going to do this in the case, so I'll pull it back. Um, Big things that relate to your risk factors that I ask about. If there's anyone asking about substance use, but especially if there's someone who has a substance history in the past, even if it was like I'm seeing a 40-year-old patient and they're like, oh yeah, I struggled a little bit with like alcohol when I was in college, but that hasn't happened in a long time. Like kind of a
Mhm.
pan review of if their coping mechanisms that they use or have used in the past and felt over reliant on have changed is something that informs me in terms of one of the ways of how much they're struggling. Another part is being thoughtful around medication change timeline. I think if you changed a medicine 1 week before, you might be like, oh, this is doing something or making something happen, right? But what can happen in outpatient, especially, is like you decide to like cross taper from Lexapro to another SSRI because they're experiencing side effects. And then someone misses an appointment and they were supposed to see you a few weeks ago, but they haven't seen you, whatever. And suddenly they were on Lexapro, let's say like 20 milligrams, like a high dose. And they've been living at Lexapro 5 now for 2 months, and you've decreased their prior somewhat effective depression medicine. So
Mm.
just being very thoughtful around not just immediate med changes, but like, are they it can be easy to kind of lose sight of the changes that have happened slowly, given that we don't necessarily see the impact on mood disorders for a while until they're off the med.
Yeah, it's really interesting to think about like while we're trying to treat someone, we temporarily can introduce some instability.
Mm-hmm. Mm-hmm.
We're making a med change, and that kind of it changes the status quo, and it can change people's coping skills and also the amount of distress they feel.
Right. Right. Exactly. Yeah. Um, and then I think changes other things like a couple things, relational changes. So not just like someone's going through a breakup or grief, but like people changing like part of life they're in, like someone who's been like a stay-at-home mom and her last kid is now off at college. And
Hmm.
the marriage relationship is okay, but sometimes not great, and she's not necessarily involved in the community. So how
Or like
populated is
retirement.
yeah, like how
What
populated
I
is
think
this
of.
person, or someone who's like post grad and they just moved to a new city where they don't know anyone and they're an intern. Maybe you're one of our listeners. Um, and they don't really know anyone in the city and they're working all these hours and they're stressed and there's not a lot of close relationships around them that they feel connected to. So just how is their relational world peopled or become unpeopled in some ways, and like
Hmm.
connections on many different levels to that. And then the last thing that I think about as well is like lifestyle factors. I think this gets underestimated sometimes. Like it's not like getting one bad night of sleep is going to make someone's suicidality risk go way up, but like if they are suddenly struggling with insomnia in my postpartum patients, right? If they're now not sleeping because they're waking up constantly to feed a colicky baby. We know, and we've talked about how exercise and mild to moderate depression can have this near the
Hmm.
same effect size as like an SSRI. So if someone has had an injury, now has pain, and they haven't been able to exercise, just all of these things and helping us figure out the story. Even if we aren't super certain, I do think having a story in and of itself can be protective to be like, well, we can change these things and have hope around changing them,
Mm.
versus, to use your term, like kind of total chaos that we have no impact on at all.
Hmm.
The second thing I would say is I put run the scales. I was in a mood when I wrote this. um, I do think that pairing the narrative with the kind of psychometric data is super important, especially in inpatient in the ED, but in outpatient in terms of like where does someone sit with their like PHQ-9 or with their like GAD-7, like where do their symptoms sit in terms of if it's worsening, as well as then the suicidal risk factors. So there's a number of ones that you can do. I know you mentioned one. This wasn't explained to me until like a year ago, and maybe I just didn't get it, but I'm going to say it for any listeners who also maybe. So the baseline Columbia suicide screening scale, and then the ASQ, the Ask Suicide Screen questions. Both of these are screens. We know this from med school. Again, this, Preston, you probably understood this from the jump, but my brain was like, what? Those ones let us know if we need to explore further as screens. And then for my institutions, we use a suicide risk assessment that basically talks about all the modifiable and non-modifiable risk factors and prior acts and self-harm and other kind of diagnoses. And that we do if they screen positive on these other two. So from like the data, considering if you're in an institution that regularly collects it, where are they at in terms of the symptomology of their depression, bipolar, is harder to measure, but depression, PTSD, and like anxiety, I think about. And then also like doing the stepwise assessment for the risk factors and documenting all of that and all of those things. So pairing that, I think that's also just important from the bias perspective. Like there is a lot that can come out. This could be a whole episode, so we won't get into right now, but like in this chapter I was reading in the textbook, it was like, sometimes clinicians can feel countertransference towards patients who express suicidal ideation. And it was like, they could feel this, this, and this. It is literally, there's a sentence like, it is called countertransference. So there's a lot there that we won't go into, but I think pairing the narrative with some of this subjective questions, but more repetitive data over time gives us a more robust picture and also doesn't make the patient feel like we're either being like, okay, answer these questions, and if you answer it in a certain way, then I'm going to send you to the hospital or not, whatever. Do you have any other ones you think about for like the psychometric data?
When I'm trying to assess for suicide risk?
Yeah, or when you're like, let's say you're in an outpatient encounter and you've done the suicide kind of risk stuff, is yours different in terms of the workflow?
No, we use the same like psychometrics. I don't know. I can't, maybe I don't take advantage of psychometrics as much as I should or I could. I think I tend to not put a lot of value on them because I see them as like screeners from the start, which lead you to do more investigation. But like I'm doing that investigation right now, while I'm talking to them, So I see their utility in like, attached to a clipboard in the waiting room, but not necessarily as much like in the in the visit. And I think this is like something that I've kind of gone back and forth on too, where like PHQ-9s are really effective at screening for depression, but then a lot of studies will use PHQ-9s to trend to depression or try to like mark like treatment recovery. And that's like not nearly as accurate.
I think, so I agree with you. I guess ours, in my system, it's sent over Epic before the visit as like, please fill this out before your visit. And then I have like a graph as a dot phrase that auto-populates. So it's not a lot of like legwork for me. It's more like I can look at this, and if they went from like, they've been at 4, 4, 4, 4, 4 on like the GAD-7, and now suddenly they're at 20, like, I'm like, okay, good. And I do think there's something about that it's the same each time in terms of chances of at least giving us something to reflect on and to
it's showing you an objective huge change from their baseline.
But it's like, if I just send those to everyone or have them fill it out, I would be way less incentivized to use that data. But I do not.
Yeah, that makes sense.
And then the last thing before we do our couple case examples that Preston is going to be a brave psychiatry resident and I'm going to be the patient, so we said find the story, which is like the narrative part, and get the metrics, which is the kind of numbers, objective, anti-bias part, as well as in that is sort of the like legal and billing is these requirements of that part that they want to see, which I think is actually fair in this case. And then the last thing is increased level of support in most cases. And that we can be creative with that. In an ideal world, there would be a continuum of care, all like from an outpatient clinic with increased access to see you like weekly instead of once a month, to be able to connect to a social worker or like an RN who can check in during the week, to partial programs virtual or in person to residential inpatient. In an ideal world, everywhere that would be possible. I'm from a college town and not Boston, so that is very much not possible everywhere. But
Mm-hmm.
I do think this is where the cliche "don't worry alone" comes in. Especially don't hold the risk alone in outpatient. So increasing seeing you, and then possibly thinking about like, what is your clinic or practice setting that you're in? What are the other things they have for this kind of, that is like one of the benefits of being in a group practice or an institution, is that there is more like of a
Mm-hmm.
standardized way of how do we hold people when they are more acutely sick and they aren't hospitalization level yet.
One thing that's really cool that my program does is we have this thing called the living room, which is like, it's just like an open, basically like coping station
Wow.
where it's got like aromatherapy, it has couches, it has like games, journaling, things like that. And it's staffed 24/7 or like,
Cool.
not 24/7, but like during all work hours by a psychologist
Wow, that's
or
awesome.
like a psychology like intern.
Mm-hmm.
So anytime if someone feels like they're in crisis, but they're like not at hospitalization level, they go to like our living room. And then they just kind of sit and they cope with them. They walk them through exercises and do different things together for like 90 minutes, 2 hours. They kind of continuously check in, and then they make crisis response plans or safety plans with them.
That's cool. Yeah.
And if they need to, sometimes they go into the hospital, but sometimes they just kind of go
Yeah.
straight from there.
We don't have any. That's awesome, first of all. Like, that feels like this kind of creative continuum of care that offers these kind of in-between spots so people don't have to go into the hospital if they like not indicated, or it's just like really like not been helpful for them in the past. We have like an urgent care psychiatry clinic that we do that is like walk-in. And that has social workers for like emergent, kind of similar, not therapy, but just like this person doesn't have care, can't be seen by someone, their psychiatrist today or their therapist today. And that has been a really cool model that has only come into existence in the last like a few years, I think, for us. So besides increasing contact, there's also getting a little bit more aggressive with your medication management. We know if someone's like struggling with depression, like classic depression, SSRIs aren't really going to help from a physiologic standpoint in the first couple weeks, but you can create a more aggressive plan. Like maybe in a like someone's doing fine, but they're having this side effect on their antidepressant. Maybe that taper looks slower to avoid side effects, avoid whatever. Maybe you get more aggressive in outpatient where you're like, I'm going to see you in 2 weeks. I'm going to increase the amount of times you see me. We're going to come down by this amount this week. And then the next week, I want you to come down by this amount without me. Like, I won't see you in the in-between week. And then we will start the other one. So like increasing the timeline to a certain extent, as much as is possible when they're outpatient, as well as considering more use of like as needed medications depending on their diagnosis. So like if they're having panic attacks, if they're really struggling with sleep as part of their illness and it's not like mania, but it's like part of depression, like freeing up your ability to use benzodiazepines or sleep medications or other things like that to get through this crisis period. So protecting the lifestyle factors that we talked about earlier that can further destabilize them. And then the last thing, just you mentioned this a little bit with treatment for acute, kind of studies on acute forms of like CBT and DBT have shown like to be effective in reducing suicide attempts. There's also been some studies in psychodynamic and like family therapy and interpersonal that have had like RCTs for effectiveness. The other thing that they said in the textbook that I just thought was interesting before we do the cases was there was a heading in the chapter that was like supportive calls and letters after discharge from the ED, which kind of is like, yeah, support is good. But one of the things they mentioned in the text was thinking about how different forms of technology or apps or like well-rounded care could exist in that way of connecting through like a health app or with like health coaches or things like that. So I thought that was interesting, and that was, they've done studies on like places where they reach out after discharge and like with a phone call, whether from the clinician or from like an RN or an MA or other like integrated care, that found it to be somewhat protective and like reducing the loneliness, and also that kind of factor we talked about last episode of suicidality, of feeling disconnected from people in the community, and that even 5-minute like phone calls were found to be useful.
I wish we could prescribe friends.
Maybe the real
Like, just
antidepressant was the
like
friendship we made along the way.
no, but yeah,
You're
like
real,
go pick
yeah.
up your friend at the pharmacy, and they're they're gonna genuinely be invested in your life and hang out with you and do things like if that's something we could prescribe, it'd be such a protective risk factor.
Right. No, yeah, I know. Sometimes I get like not when someone's super actively in like acute depression, but I do think sometimes speaking to these kind of studies on like lifestyle factors and belonging in community and pushing our patients a little bit more in that and using our like power that we have in this system to help legitimize like, no, that really, I know you know it, but like, what are ways we can think about this? And I'm going to put it in my note and ask you about it in 2 weeks when we check in and see how it went. And if it didn't go well, that's okay.
Mhm.
Like, we'll try something different. But I do think we have a role actually in like helping to remind people, not know like, you should exercise, it's good for you, but actually like, they're in crisis, they're depressed, their thinking is not as clear. We can help with that.
Mhm. I try to like make people if they don't have hobbies, I push my hobbies on them. Not really, but I'll be like, "Oh, do you like walking? Like, what about this walking group?" And I'll like search like I'll like look it up in front of them. Be like,
Yep.
"They're near your house. Like, how about that as a goal next
Hmm.
time? Just attend one walking group
Yep.
on
Yeah.
this day." And like be very very specific about it, not like you should walk more or something. Like,
Exactly.
no. I want you to
Exactly.
go to this walking group and tell me about it. And like maybe help to be like less paternalistic about it
Mhm.
because then if like they go and it sucks, they're like, I hated it, but you want it to be like their idea.
Yes.
So
Yeah.
I try to be like keep it open, like what's the thing you could do? Okay, how about this? What are your thoughts about that?
Yeah.
But sometimes when people don't have any motivation to try anything, then I'm kind of just like, you can hate me if it sucks, but try it at least.
Yeah. Yeah. I mean, also, it's like if they're super depressed and like there's like, very strong anhedonia, like fatigue, amotivation, definitely this isn't the right approach. I'm not like drop and give me 20 exercises good for your depression. Get out of my clinic if you don't want to show up.
Yeah, I'll
But
see you
yeah,
at the gym.
I'll see you. Yeah. But no, I think the getting specific, getting creative with people, and also the like to the point of like follow-up calls, literally put in your note. I put a note to myself of like, there's like a lifestyle, like whatever problem in my problem list under like therapy, medications, workup, whatever. Um, and I will put like the thing that we talked about probably impacts their mood the most and be like, they said they were going to go to Zumba once before they next see me, ask about Zumba. And
Hmm.
just remembering and asking. And then they know that you actually do remember and ask, and not in the like, did you do this or else, but just to like,
Hmm.
someone else is invested in you and cares about helping you build a life that's meaningful to you, despite and with and alongside the depression, can be important.
Yeah.
That's my thought. This is my like soapbox as outpatient chief this year is like, just ask them about it the next time. Like, remember.
Yeah. I'm going to like a full outpatient panel starting in July, so I'll be excited to employ some of these. I did have a question about safety planning.
Mhm.
So how do you incorporate that into like the outpatient interaction?
Yeah. So I think that with safety planning, this is like the like schematic of it. First of all, I have a dot phrase that is like the safety plan that I think if you Google safety planning, it's like the one.
The safety plan.
Yeah. So I don't use that as much anymore. But with safety planning, so once you kind of understand the story part helps us figure out what are the most possibly predictive changes that we can make that can help with stabilization. So let's say someone's pain is worse. Maybe that means part of like, so thinking about reducing where we can any kind of emotion distress, doing that's one bucket. The second bucket like is after you assess where they're at with do they have access to firearms? Do they have these things that they've prepared? Are they like living alone? Are they having contact with people? Is asking the question, okay, if these thoughts came up again, like if you had the urge to go to Walgreens and get a medication you could overdose on again, what do you think would happen next? And how do we make a cope ahead plan Like,
Mhm.
how likely do you feel like it is that you would go get it? And these are uncertain questions to ask, but they're kind of all we have. And then you don't say promise, because there is pressure on the patient to like kind of perform and say, no, doc, or like, I won't do it, whatever. But
I would never.
but using the relative calm state they're in now to help them with this like elevated crisis state that they'll probably go back into, to say, who would you call? Can we write this down? And I will write this down in the note so they have it. Like, okay, you could call your friend, and like, if they're like, I don't want to talk to them about it. Can you call them and just say, I've been having a hard time? See how much they're willing to reach out. That's also part of the risk assessment.
Yeah. One thing that I've found, and maybe this is like me learning how to deal with these type 2 chaotic systems, is that when I introduce it as a safety plan, there are a lot of patients. There's like a certain demographic of patients that will have a lot of resistance to even like the mere suggestion of a safety plan. But then when you kind of put a veneer or like relabel all the same pillars of that plan, all of a sudden it's like a lot more better accepted or tolerated.
Well, I mean, I think
So, like,
the disliking the safety plan makes sense. Like, it's become a thing that we have to do for billing. So they're like, yeah, da da da.
it sounds trite.
Yeah. And it can be done tritely very easily. Like, just being like, okay, what are 3 things? I mean, we've all had maybe not all, but we've all had the experience of being like, this person's discharging in 10 minutes. They have to have a safety plan in their chart. Go do it. And being like, who are 3 people you live for? Like, that safety plan sucks. I would be trite about that shit too.
Or they're like, I told you I'm not suicidal. And you're like, but if you were.
Right.
And they're like, I've never been suicidal. I'm like, but if you at some point in your life became.
Right. And they're like, yeah, I guess not. What do you want me to say? So I often word it as an outpatient, but I think I would do this inpatient too now at this point. I will word it not as I'll say, we're going to do a safety plan, but what I really mean is making a plan for you to be more supported and less alone in this for now in the next couple weeks. And so we can use our brains right now together to help you know what to do if this feeling kind of elevates again. So maybe try that.
I might be too vague with it, but what I found has been helpful is, I mean, these are like patients with antisocial traits and substance use in like South Texas.
I like how you're like, they didn't like what I said. So there's resistance and they have antisocial traits.
Yeah, that's my countertransference. No, but like I'll be like this is how a conversation will often go. So, would you be interested in making a safety plan? You know, I'm not fucking safe. If you put me back out in the streets, I'm just gonna kill myself again, or I'm just gonna try to kill myself again. I'll be right back here. Is that what you want? I'm like,
yeah.
Cool. Nice.
Yeah.
So no to the safety plan. Take that. But then what I found instead is if very like almost like disarming, just kind of like hands in pockets, casual approach. I'll be like,
I'm just picturing
what
you like
stresses
scuffing
you
your
out,
shoe
you know?
while you walk down. Like,
yeah, I'm like on my like pigeon toe, and I'm just like, so man, what's been stressing you out lately? Oh, you get stressed when you don't sleep very well, and so instead of saying what are warning signs that I might be suicidal, I'm like, what are the things that make things tense for you? And then instead of following up by being like, what are your coping skills? Have you tried deep breathing, while you're out in like the 100-degree heat, like underneath the overpass? I'm like, you feel kind of dumb about that. But then you can say like, how do you de-stress? Like I've found that instead of saying like, what are your coping skills? How do you de-stress as kind of like a good lateral exchange?
Yeah.
And like that has like nearly 100% success with me. Everyone likes to talk about how they de-stress. No one likes to talk about how they cope.
Right.
And you're like, okay, you're right.
I do.
It's way different.
In the children's hospital, we have to do, it's like not even a safety plan. It's like you've maybe seen something like this. It's like a thermometer and it's like an emotional intensity chart. And then like things associated with those, like people events, and then things that make it go from like an 8 to a 5 on the intensity. So I'll often speak to it that way of like what turns the volume down. Like if you are feeling really, really like lonely, and that is the emotion associated with when you start having more suicidal thoughts, like what is something that alleviates it 10% or just turns the volume down and makes it less all-consuming, or what is the thing that makes it go up? I don't know. I feel like I haven't been an inpatient for a while, and the conversation has a different tenor when you're an outpatient because it's like not as adversarial because you're not in a locked unit.
Yeah, and I'm not seen as like the prison warden while I'm also trying to like navigate like the eggshells of the conversation
Yeah.
to get hopefully something like meaningful out of them.
Yeah. I will say something for you to look forward to is I feel like all the safety conversations I've had most of the safety conversations I've had in outpatient have been like, you also just know people. I don't know. I feel like I know my longitudinal patients better. They've been mostly like meaningful and there's not that feeling. I think I had more of it when I was inpatient of like the kind of conversation you're talking about that's like, what is this? What are we doing? Like, you've been here for 5 days, now you're leaving. And I'm just like, what are 3 hobbies you like to do that will make you less suicidal? Like, dude, that sucks. Um,
Yeah.
and I also think there's something in residency about like, they're discharging, you're not going to see them again. There's that part of it. But it's like when you're an outpatient, you staff with attendings, but they are your patients. And like you truly are the one who
Mhm.
knows them the best in the clinical team. And so I think there's also something that is creative and more personalizable when you're the like main person helping them come up with it versus just being like a resident in an inpatient unit where they were there for 4 days who's like has to go do this before they
Yeah,
leave.
like to them, I'm just a rotating badge.
And that's what you are to me too.
It's fair. And sometimes it's nice. It's like Groundhog's Day a little bit. Like you go to talk to a patient and they've completely forgotten you from the day before. Does this ever happen? Does this happen to you when you're inpatient? I feel like this happens to me on consults all the time. And they'll be like, yeah, the psychiatrist before was asking all these invasive, annoying questions, but you're cool. And I'm like, that was me yesterday. I'm just literally in a different outfit.
They're like,
And
well,
so
all right, Dr.
and I'm like,
Jekyll
well,
and
I'll
Mr.
try again
Hyde.
tomorrow, and we'll kind of
They'll
see
be like,
which interview style
oh,
you
you're that
resonate the
guy. I
best
hate
with.
it.
Yeah,
you're like, I do come in some
he
days wearing
sucks.
wigs. Like, just don't recognize me.
Yeah,
It's so weird.
just take off the mustache and the glasses. They won't know what hit them.
I just thought, okay, I'll tell you this later.
I just think that rapport is necessary for these kinds of conversations, and I
Yeah.
think we try to do in a lot of ways like a bastardized version of a procedure that needs a lot of mutual trust and rapport.
I think it
And
does. I also think there are like people who are really good at the inpatient setting that like they understand the frame so well that they know how to build rapport within that frame. I feel like this after moonlighting for the last couple of years that like certainly I prefer not weekend rounding, which is what our moonlighting is for psychiatry here, because I meet like a bajillion people for like 5 to 10 minutes each. And
Mhm.
but I will say it's gotten so much easier to feel connected to people in that weird setting when I learned how to like elicit, like how do I connect to people and also make them not confused about what we're doing and not like there is a lot that's limited to inpatient into that. But I also just find that there are people who are like on CL who are so good at like forming a temporary but a bond with a patient that they're only going to meet a couple times in like or 3 or
Mhm.
4 times in like 7 days. I don't know. I think there's something to be said to that. I'm not that person, but I've like seen people who are so good at that specific form of connecting in that setting.
Yeah, I've seen some people they're excellent at it too. I think I'll have times in certain patients where I feel like I kind of hit it, and then a lot of times it's just it's frustrating and it's counterintuitive.
Yeah,
Sometimes the
sure.
best thing to do is just you don't try to over explain situations, but you just like use a lot of reflections.
Hmm.
Kind of you act like surprised and share emotions with them really openly, and then just kind of like think out loud, which are like really hard things to do in inpatient settings,
Yeah.
but then are ultimately like the most effective for like building these like tight, quick alliances with patients.
Yeah. No, I totally agree. Okay. Are you ready? We'll just do one case example
Okay.
because I don't think we have the time to do two. Um, so I'm going to give you a vignette. We're going to do an outpatient one because that's what we've been talking about. And also because I think, again, the outpatient setting, it's hard because I feel like it's hard for 3 reasons. For a lot of people, outpatient is the first time when like you know this patient the best over time and like maybe you're
Hmm.
attending switch, so they feel like this is my patient. They feel like that in inpatient sometimes, but like outpatient it gets even more so. 2,
Hmm.
you're not in the hospital. So if they don't want to go to the hospital, it is a time where you have to you're not, it's hard to section people or have restraints happen, but like, are you going to send someone to their house? Are you going to like force? There's a lot more force that in some ways you have to use an outpatient if things get to the level of
Yeah.
that acuity. I don't remember the third reason I had in my mind. Maybe it never was there. But so are you ready?
Yes.
Okay. You will be graded on this. I will be sending it into the boards. Okay. So you are a third year. It's the fall in Texas. I don't really know what the fall in Texas looks like. You have just finished your mindfulness practice and you're sitting in your office and you are meeting with a patient who you've known for 6 months. You've met with them 6 times. They have a history of depression. They're a 28-year-old male. Wait, you're 20. they're a 28-year-old.
It's me.
It's not you. No, it's not.
I am you and you are me.
We are one. It's a 24-year-old male who has a history of depression that has been stable during your work together. He's had 1 suicide attempt in the past when he was 17 after a breakup. He's been stable with you on 40 of Prozac with minimal side effects. He does struggle a little bit with alcohol, mostly with a binge drinking pattern that started in college and has kind of continued into young adulthood, but has not had any complicated withdrawals or anything like that. He is living in Texas and does have a gun because he likes to go hunting and also has a handgun. My knowledge of gun is showing. Guns are showing. What is gun?
He has a big gun and a small gun.
He has a big gun and a small gun. And he's coming into your office and he sits down and looks at you and says, things have been really hard lately. And I'm feeling like I felt when I was 17. And so what we're going to do for the next few minutes, and I have a timer, is I want you to interact with me like this is the patient. And then and I want you to, let's say you already did like all the like there's nothing else going on psychiatrically. I don't suddenly have psychosis. There's no other substance or anything like that. And you've covered all of this information in the first 20 minutes of the visit. Now you have 5 minutes where you have to go you're attending, where you need to really drill in on what I mean when I said I feel like the time that I was 17 and suicidal.
Yeah. Okay. So what you're getting is like this acute safety assessment.
Yeah.
Gotcha. So around the time when you were 17, tell me about the thoughts that you were having.
I mean, I feel like I was already depressed in high school, and then my girlfriend broke up with me, and I mean, I don't even remember. I don't even feel like I had a lot of thoughts then. It was just things just felt so fucking bad that I was like, I just can't feel this way anymore, and that's when the overdose attempt happened.
Gotcha. So when a lot of people are experiencing distress or thoughts that they can't handle, they have this desire to just escape. Not just life, but the world. Do you find yourself having those thoughts?
I want to say no, but I feel like that's why I'm scared, because I feel like I don't want to die, but also if you said okay, you can go to sleep and choose that you're going to die or not, and it wouldn't hurt anyone, I kind of feel like I would choose that.
So a part of you says it sounds nice to just go to sleep and not wake up, and a part of you is scared that you may actually entertain this thought and move towards harming yourself.
Yeah, because it feels familiar to that time when I actually did.
Have there been moments during this episode where your mind's wandered and thought how you might actually do it, or maybe felt comforted by the thought of doing it?
I mean, I have we talked about how I go hunting with my brothers. I have a gun. It's locked and not loaded because my girlfriend is I just doesn't trust guns. So I know I have that, and it has crossed my mind that that's what I could use, and then that scares the shit out of me again. What was the other thing you asked?
Oh, if there was a time where the thought came up and it doesn't scare you, or has it scared you every time?
I think the idea of actually doing that scares me just because of how many people it would impact. But
Mm.
there's been a moment. There was a moment when I was driving the other day and I thought I could just drive off the road and make it look like an accident.
Mhm.
And that kind of stayed in my mind for like a moment. I didn't do anything with it,
Mhm.
but it was like not, it kind of
That
felt like
time
a relief.
it didn't go.
No, and it did feel kind of like a relief for a second. Like, oh, I could just be done.
Mm. What do you think pushed your mind to that?
I mean, I think like, I don't know, dude. Like, I've been out of college for like a year and a half. I feel like all my friends are like settling into their life in like different places. And
Mhm.
like, I have my like girlfriend, but like, honestly, it feels like it's not working. And I don't know if that's my depression or if that's us.
Mhm.
And I just feel like I like don't like my job very much. And like, I've known these things, but it just feels like it's not getting better. And I don't know if it ever will feel
Mhm.
like were my college years just my golden kind of age. And like, that's the best time of my life. And now I'm just going to feel like this
Mhm.
forever. I think that's just been like worsening. And as it gets like further out, like I just feel a lot of pressure of like, do I break up with my girlfriend or propose to her? Do I like stay in this job? Do I
Mhm.
move? Like, and that's just been increasing over the last like 6 months.
Mhm. Those are a lot of high pressure things all kind of intersecting at once. So, I mean, no wonder you're feeling stressed about it. And maybe stress is probably an understatement compared to what you're dealing with every day.
Yeah. It just doesn't feel like things are going to get better.
Mhm. So, as far as today goes, I wish I could, wave a magic wand and give you perfect clarity about what to do with your girlfriend and find you a new job. Fortunately, I'm all out of magic wands, but there are some other things that we can maybe change to make life a little bit better right now. So I know we've been stable on Prozac for a while, and it sounds like it is helping you, but you also are at a submaximal dose. So one thing we could consider is going up,
Mhm.
not because your depression's getting worse. It could just be from a response to your environment. I think we can find out. Um, I want to follow up with you again in 2 weeks so we can kind of keep a closer eye on how these medicines are doing. As far as kind of these thoughts that are dangerous to you, I want to talk more about these firearms at home. We know that you have this history of a suicide attempt, and all the factors that have led up to this are kind of happening again. What are your thoughts about um, finding someone to give the firearms to or to store them somewhere else where you're not tempted to them or don't have to think about them anymore?
Yeah. I guess I could. It just makes me nervous because like it's hard enough like telling you this stuff, but I
Hmm.
even like telling my girlfriend makes me
Hmm.
hesitate. But I think I can, and I think you're right, and I should have her take
Hmm.
them to like her place or like I don't know, take them to her like parents' place.
Yeah. If not your girlfriend, who else can you reach out to for support?
Mm. I think my sister, like we don't always see eye to eye sometimes because she's like too emotional for me, but
Hmm.
she I think would be able to talk to me about this stuff and also just like be there for me if things feel bad.
Hmm.
She lives like an hour away.
Okay, so your girlfriend and your sister. Is there anyone else in your life?
I haven't talked to him in like a year and like I've been really bad about like we've been bad about like texting and catching up. But my like best friend from college like had
Hmm.
he didn't have depression, he had like anxiety and we talked about mental health stuff sometimes and he was always like really good at that. But I could text him at the very least or like text him now or soon just to like reconnect. And I honestly I should do that anyway. Like I think the depression
Hmm.
has made me less social and like maybe reconnecting that line I think I would, if I was like, no, if those other two didn't answer, I would still, even though it might be kind of awkward, like I would be able to call him and talk to him. And if I was feeling really low again.
Mhm. I think it's a wise and a brave place to start. How about you plan to call him or just reach
Okay,
out,
let's
and then I'll ask about that at our next appointment.
time.
Is that time?
Yeah.
Okay.
Dude, good job. I thought you handled
I
that
feel like
great.
you don't see me in clinical scenarios a lot, so
I don't see you in clinical scenarios.
yeah. Well, you don't work with me. You only get to see podcast idiot Preston.
Listeners.
I'm actually okay at
I
interviewing
don't think you're
sometimes.
not okay at your
Okay.
job. Like, what do you think this is like a rehab project for me for
Yeah,
you?
you're right.
I like talked to you on the phone one time and I was like, this guy needs my help via a podcast. And that's right. No, how did that feel? How'd it go for you, for your experience?
I think it honestly felt very similar to like conversations I'll have with patients that have like I have a good relationship with, and they have like kind of insight into their concerns. So kind of like one thing that like I did, which was like what I talked about kind of going back and forth on, which is I was walking through the safety plan with you, but trying to make it feel just like an open-ended conversation.
Right.
And so I'm identifying those same pillars.
Yeah.
Of like your dissatisfaction with your job, your relationship tree, and these other things are kind of what like leads you to these suicidal thoughts.
Mhm.
And then kind of we identified that they're passive suicidal ideation, sometimes flirting with active. And so for listeners that aren't familiar, passive is kind of ego dystonic thoughts about harming yourself. And sometimes it's more morbid ideation of like, I wish I could go to sleep and not wake up. But then active suicidal ideation is where it becomes ego syntonic, where it's like in line with your beliefs and you're like okay with the thought and want to act on them.
I think there's also like the level of time. Like you had asked with like the car driving, like, okay, so that stayed with you and you were kind of entertaining it more versus like an intrusive, like I think about like patients with OCD and depression who can have like both intrusive thoughts that like flit by.
Yeah.
Thoughts that come in from depression and are like merging into ego syntonic and feeling like a relief and not just kind of an image that passed by.
I mean, I think you responded really well to like my reflections. So I love to use like nuggets from motivational interviewing with patients as soon as I identify any kind of tension. And like suicide is a great example of where there is tension in someone because you have these thoughts about killing yourself, but you're clearly alive. So inside of you
There's
is a
different
lot of
parts that-
stuff
yeah.
that's pulling. Yeah. So then just being reflected, like a part of you feels this way and a part of you feels that way.
Yeah.
I think it can be like eye-opening to people who have trouble kind of engaging with that dialectic.
Yes.
But then also it shows an understanding of them.
I mean, I think you did a great
So-
job of keeping it as a conversation and a narrative while also getting the kind of hitting the things, even when it was hard, even when I kind of purposely dropped the like, it just feels like things are hard and are never going to get better, right? Like the reality of our clinical time is that while that sentiment really pulls for empathy and to have you slow down and not have to ask like, okay, well, I need to ask you these questions about, are you going to, do you have guns? Like that you were able to keep going. I think that is though also a tension point in these kind of interactions when someone's really struggling is, will you keep the patient if you push for more data, or will they feel unheard and start to disengage from you? But I thought you did that well. I think you were good at like eliciting from me more of the engagement with the safety plan to make it personal and not just like, I'm going to list 3 things that I feel no salience to. Yes.
Yeah, no, I agree with that. Like I'm thinking about all like the shit safety plans I've done so far in residency and like how hard it is to do them effectively and personally.
Yeah. I think the one part maybe where it was not a misstep, but like maybe would have made a different choice on like the wording of like, I don't have any magic wands, but maybe would have had a little more empathy. It can come across as kind of like, okay, well, I don't have anything that can do that, but this. So, but I hear you on
That's
a
good feedback.
minor gripe.
So the reason why I use that like line sometimes is I stole it from palliative. They do this like kind of like the wish and worry.
Yeah,
statements.
I love the wish and worry.
And so that's kind of what I'm doing. I'm wishing with my magic wand, and then I'm worrying about this. So what I try to say is like, I support you and this is what I wish I could do for you. And then also I need to ground us in reality and what is actionable now.
Right.
And sometimes I think maybe I try to kind of rush that bridge.
Yeah.
So I think, yeah, you're right. It comes across as like, I wish I had a magic wand, but also I can't do shit.
Yeah.
So you have to do this other thing.
Well, so maybe like when it's not rushed, I'm not putting you on the spot. I think one of the ways to do it is to be like, slow down for a moment with the empathy part and kind of say, it is so difficult that like, whatever in your voice, like it's so difficult that this is here. And we have to talk about all these small things that hopefully add up to helping you. And I so wish that we could just change it right away because you're in so much pain right now.
Yeah.
And then moving. But
kind of sitting with
that's a stylistic comment. This is also finishing the psychoanalytic fellowship. This is what we do every Thursday night for 4 hours. Be like, you said this, and I wonder what you were actually internally feeling, and how. And then they seem to do this. So you're getting some of that. I'm sorry, but it's been so helpful for me.
Yeah, well, it's helpful for me secondhand. This is. I know we're wrapping up.
Yeah.
This is a question I had that. And this could be a whole other episode, but I feel like I've been trying to use I call it like intentional unprofessionalism or like professional unprofessionalism, which is where like you reflect the patient's language and like openly like cuss with them or things like that as a way to kind of like validate their experience.
Mm-hmm.
So like, for example, when someone's like, I've been hearing all these fucking voices everywhere, and I'm like, that fucking sucks.
Yeah.
And they're like, it does.
Yeah.
You know, like there are a lot of people that kind of use these like political, detached, like robotic language around them. And then when you're the first person who can like reflect their language back to them, even though it's like wouldn't be considered professional in a lot of clinical environments to be cussing like that, they see it as very humanizing. And it kind of is to be like, hey, I'm going to cut through all this BS and be like, acknowledge that like sometimes the best word for a situation is like, that's a shit show.
That's fucked.
Because sometimes it is a shit show.
We are losing the battle of ever having a non-explicit episode right now.
Yeah.
Every episode's rated E.
E for everyone. We can get into maybe the more Half-Blood Prince style versions of supportive psychotherapy later.
What was your question? Just should you do that?
No, yeah. So my question was like, do you have an opinion on that? Like,
I have the frustrating opinion of it depends. Like, so for example, let's say I have someone in my clinic who has been a population of people that has been underserved by healthcare, discriminated against by healthcare, been literally mistreated by clinicians in the past, had someone break a boundary, all of these things, right? Or let's say I have a female patient who's very, very like blocked up and anxious and can't show any anger or assertiveness or be imperfect. With her, I might on purpose cuss and like not do my makeup that day that we have therapy together to reflect that is okay in this space. And that kind of edge is all right. I'm not that thoughtful all the time with people, but there is that level of like, do I bring this in? I think there's also just something to be said about like, your personality will come through and is part of how you work with people. And obviously I cuss, you cuss. I do cuss a little on TikToks. What's your favorite fuck?
What's your favorite cuss word?
So I don't ever try to fully be a blank slate, but I think there's kind of the knobs you turn on which parts are important for people is not inauthentic. It's just like, what's important here? Because all of us have these like 1,000 facets of us. And as a therapist,
what levers of myself kind of used to be most effective here?
Whereas if there's someone who's like also very professional and seems like it could be a very similar patient, but they are someone who seems like they really value professionalism or they are someone who doesn't believe in like cursing themselves. So it makes them uncomfortable. Or if that's what I'm sort of picking up, even if it's like they actually ideally someday want to get to the point where they're more comfortable with anger, edge, or imperfection, but they're not there yet, then I won't do it in that session.
Yeah, they won't try to shatter the decorum.
Right, because it's like it's in psychoanalysis to say it's like it's not in the neighborhood of the knowing. Like it's not gonna do that, right? I think that's my view on, or it's like they have someone who like has been too personal and like not cross boundaries in like a crime way, but like someone who like would tell them things about their lives as a therapist or cross lines that way. I will be purposely more professional because they've experienced those infractions. And maybe that'll relax over time, but like Yeah.
No, that makes sense. Like I have patients who they've had therapists before them where they were like literally would tell them what to do. Like, you are going to do this.
Yeah.
And like you're going to make a resume and I'll review it at the next session. And then with those patients, I'll be like very deferential with them. And I'm just like, I won't give you any advice. This is all in your ballpark.
Yeah.
I think that's a good way to wrap up
That could
the
be a
episode
whole
today
episode.
before we continue.
Just psychodynamic
continue to
questions
ramble
and
off
answers.
into the sunset.
Yeah. Well, oops, we're having like a 2-hour episode.
Yeah, Yahtzee.
Whoopsies. Sorry, guys. It's a treat. Even a little extra of the treat today.
Yeah, hopefully your commute's a little bit longer today.
So I can say the username this time because it's Psychiatry Intern, and they left this review on Apple Podcasts because reviews help us, even the ones that are tell me I should shut up. But this one didn't do that. What if I said the one that was like, you should stop laughing, cut it off? I'm like, girl, I can't. I'm sorry. Okay, the real one though. As an incoming psychiatry resident, How to Be Patient has been very thought-provoking. The hosts, psych residents themselves, bring a refreshing mix of clinical insight, self-awareness, and humor to each episode. I love how they weave pop culture into deeper conversations about identity, growth, and what it really means to care for others and ourselves. Their honesty and relatability make the podcast be like a conversation with trusted mentors and friends. I love it. 3 exclamation points. Thank you, Psychiatry Intern. We do read these.
I'm going to use that person represents all psychiatry interns now.
Mm-hmm. They all love it.
We are ubiquitously loved.
It's okay. The hate is so good for developing a stronger sense of self. She says to herself in the corner.
I just want you to know, if you leave a hate comment, it's probably going to be screenshotted by Margaret and sent to me.
And say,
and then stored in my favorites folder.
Why are you saving them to your favorite? You're like, I save every photo you sent me to my favorite.
Yeah, so thank you, as always, for listening, for all the kind comments, for all the hateful comments. They are all going in our portfolios. If you want to let us know how the show was and have pointed feedback, we also want to hear it.
Yeah,
we may or may not laugh more or less, but especially things around like the topics you want to hear or questions that you want to ask or want us to ask, they can be very helpful. So on Instagram and TikTok at Human Content Pods, or you can message us at How to Be Patient.
We are on Instagram now.
On Instagram,
not really TikTok.
It's like our own little Neopet. It has like 2,000 followers now. Yes, and so both Margaret and I monitor that account. So
with no schedule,
we'll DM people and all. Yeah. It's just like in the evening doom scrolling, but we'll come across it. Don't worry.
We will come across it, and then they'll be like, "Have you ever messaged someone back when they DM us?" And then like I had multiple people be like, "This is Margaret, isn't it?" Because they're like, I can tell by how you talk. Yeah, girl, it is.
If you want to see stuff from just Margaret, she's on Bad Art Every Day on Instagram and TikTok. And if you want to find stuff from just me, I'm at Presro on TikTok, and it's Presro on Instagram and YouTube. The full videos of the podcast.
Sorry.
I'm on Red Note, but not Lemonade.
You stayed there?
Oh wait, Lemonade?
Lemonade.
Like lemonade?
No,
but it's like lemonade.
Yeah.
It's like the pun.
It is. Are they not marketing this hard at you? They're trying to get me and all the aesthetic Pinterest girlies on there.
No, they got me with Red Note. I'm staying there. Shout out to Psychiatry Intern for leaving that wonderful feedback, and everyone else who's been leaving feedback. We really cherish it. Thanks again for listening. We're your hosts, Preston Roche and Margaret Duncan. Our executive producers are me, Preston Roche, Margaret Duncan, Will Flannery, Kristen Flannery, Aaron Corney, Rob Goldman, and Shanti Brooke. Our editor and engineer is Jason Portizo. Our music is by Omer Benzvi. To learn more about our program disclaimer, ethics
our babysitter
policy,
producer is Tessa. Our babysitter tonight.
Thank you, Tessa. To learn more about our submission verification licensing terms, our HIPAA release terms, go to howtobepatient.com or reach out to us at howtobepatient@human-content.com with any questions or concerns. How to Be Patient is a human content production.
How to be patient.
Thank you for watching. If you want to see more of us, or if you want to see, this is Lilac, she's my cat. She's going to be waving her hand at one of the floating boxes, which will lead to more episodes. Lilac, point to the other episodes. Lilac doesn't know what the internet is, but I swear they're there. They probably exist for real. But in the meantime, I'm just going to pet Lilac, and then I'm going to go dance in the background.